taking a class on a general surgery topic that happens to be shock. Can you guys hear me? Is the audio clear?
Yes, ma'am.
Okay. Speak loudly. Oh, okay. Shall we begin?
Yes, ma'am.
Okay. Okay. So the topic for today's class is shock. This happens to be a very important topic, not only in surgery, but also in general medicine, pediatrics, and even orthopedics. So this is a general surgery topic. So starting off with the definition of shock, it is a clinical syndrome which results from inadequate tissue perfusion. So what you need to remember is inadequate tissue perfusion. So that is what is important. So this is the keyword here. So we'll look at the different classifications of shock. The one in Harrison's, the one given in Harrison says there are 6 different types of the shock. First one is the hypovolemic shock, which is the most important one for our discussion. Hypovolemic shock. Next, we are having anaphylactic shock. Then we have septic shock. Then cardiogenic. You could just scribble this down on a piece of paper. Different types of shock. Then neurogenic, and hypoadrenal. Okay. So these are the different types of shocks. So first one we're going to do is the hypovolemic shock, which happens to be the most common type of shock that is clinically encountered and happens to be the most important type of shock. So let's start with hypovolemic shock. So the term says hypovolemia means decreased volume. So it could either be loss of blood, so there is blood loss, or plasma loss, or loss of water and fluids.
Okay, ma'am.
So blood loss, as in it could be because of, let's say, trauma. Okay, there's a polytrauma patient met up with a bad accident, lots of blood loss, or it could be even a surgery. So there is blood loss which will result in hypovolemia. Then plasma loss might be because of, let's say, things like burns. So in burns, there is loss of skin, there is loss of the epidermal cover. So hence there will be other mechanisms will play, and then there's loss of plasma. And another typical example is going to be the third space loss, so that's pancreatitis. Acute pancreatitis. That is nothing but sequestration of fluid or third space fluid loss. Next, water plus fluids. This happens in case of vomiting and diarrhea. So if there is severe vomiting, diarrhea, you're going to lose both electrolytes, that is sodium, potassium, as well as water. So these are the causes of hypovolemic shock. So now let's say there is already hypovolemia that has happened. What is the mechanism of shock here? So decreased intravascular volume, that is of your losses, the different types of losses we've seen. So because of decreased intravascular volume, what happens? The venous return will decrease. That is the blood going to the heart. So if the heart is receiving less, it's going to pump less. So there's going to be decreased cardiac output. Once there is decreased cardiac output, the perfusion will reduce. There is reduced tissue perfusion. So a very definition of shock was decreased tissue perfusion. So here we have shock. Now what happens because of decreased tissue perfusion? There is going to be accumulation of the metabolic products, especially the lactic acid. So lactic acid accumulates, resulting in what is called as the acidosis. So this is because of accumulation of the metabolite lactic acid, which is called metabolic acidosis. Now, the body will not keep watching this. The compensatory mechanisms will to play. Once there is decreased cardiac output, what happens is body is going to activate the sympathetic system. Everyone with me, or should I go a little slow?
No, ma'am. It's good, ma'am.
Is the speed okay? Fine.
It's
So we have the compensatory mechanisms, that is the activation of the sympathetic system. Once the sympathetic system is activated, we know that there is release of noradrenaline and adrenaline,
adrenaline.
right? So
Yes,
this will act on the heart. So
adrenaline.
it is going to cause increased heart rate. So it's going to cause tachycardia, right? So we know the first sign of hypovolemic shock, that is tachycardia. Then it's also going to act on the vessels, that is peripheral vessels. It causes contraction. So it results in increased peripheral vascular resistance. Okay.
Okay, ma'am.
Now, there are two important formulas that you need to understand that you must have read in physiology already. Write it here. So, your systolic blood pressure is going to depend upon the stroke volume times heart rate.
Yes,
Correct?
ma'am.
And your DBP, that diastolic blood pressure, is dependent upon your total peripheral resistance or total peripheral vascular resistance. So, as you can see here, if the vascular resistance increases, what happens to the DBP? The DBP is going to increase.
Increase, ma'am.
Okay, is this clear?
Yes.
Okay. So, because of the sympathetic activation, there's going to be tachycardia and increased DBP. So, this is in the compensatory phase of the hypovolemic shock. Now, because of decreased perfusion, tissue perfusion, let's say decreased blood supply to the brain. So, what is it going to cause? The patient will go in for confusion, altered mental status.
Yes.
Okay.
Yes.
Then decreased blood supply to the kidneys will result
Urine
in
output.
oliguria.
Urine output less.
Yes, yes. So it's going to cause oliguria. Then decreased blood supply to the peripheral system, the peripheral vasculature. So
Hypotension.
it's going to result in cold and cold, clammy skin. So basically, peripheries will become cold. So these three are the important, again, clinical features of hypovolemic shock. Okay, so this is the compensated version. Now let's say if the body, okay, is trying to compensate, but it has gone beyond its control. So there is excessive amount of fluid loss. The compensatory mechanisms are not able to cope up. Then it will result in hypotension. Right? So
Okay.
there's going to be hypotension. We have seen that there is increased heart rate, that is tachycardia. Initially, there is increased DBP, but later on, it is going to result both decrease in SBP and DBP because of excessive fluid loss. Okay, fine. Now we have to look at the classification of hypovolemic shock. So this is an extremely important topic. So I'll just take another new table here. Okay. So let's talk about the different classification. We have class 1, 2, 3, 4. So we're going to look at the different parameters here. Okay. Class 1, 2, 3, 4. First is we are going to look at the percentage of blood loss. Okay.
Yes, ma'am.
For here, class 1, it is less than 15%. Class 2 is 15 to 50%. Class 3, yes. Class 3 is 30 to 40%. Class 4 is more than 40%. Right?
Okay.
If we have to tell this in terms of the quantity of blood. Quantity of blood. So then I'll mean it is here less than 500 ml, 500 ml to 1000 ml. Here up to 1.5 liters of blood is lost. Here more than 2 liters of blood is lost. Okay. So looking at the quantity of blood loss, we are going to classify them. And now let's look at the features of the different classes. Okay. We are talking about pulse rate. Then we'll talk about the SBP, that is systolic BP, then diastolic BP. Then we are going to talk about the urine output. Very important. U bar O is urine output. And the mental status. Okay. And then what are we going to do about it? The management aspect. Okay. So pulse rate. We have seen that it's going to cause tachycardia, right? So is this understood?
Yes.
Tachycardia. Next, here the tachycardia, let's say, will be up to 100. It will be less than 100. So here it will go from 100 up to 120, 122, 140, more than 140. Okay.
Okay, ma'am.
Now, initially, what happens in the class one, the compensatory mechanisms are acting. Hence, your SBP, DBP, and your urine output, almost everything will remain normal. A best way
Yes,
to
ma'am.
remember this would be blood donation. Have you donated blood sometime?
Yes, ma'am.
Have you donated blood sometime? This is what is going to happen. They're going to remove around 300 to 400 ml of your blood, so which is around less than 500. So it is nothing but class 1 variety. So, but it doesn't mean you're going to go into hypertension. So your pulse rate, your SBP, DBP, everything will remain normal, right? This
Okay.
is an example of class 1 hypovolemic shock. Now coming to class 2. Class 2 is something that we have studied already. So yes, it's going to cause increased pulse rate, and the SBP is going to remain still normal here because compensation is still happening, and the DBP is going to increase. So I've told you why. Because of increased peripheral resistance. Is that clear?
Yes, ma'am.
Right? Increased DBP is going to cause peripheral resistance is going to cause increased DBP. Okay, that's the whole point. Now the urine output will start to reduce here. Urine output will start to reduce, and the patient here will develop some kind of anxiety and uneasiness. Right?
Okay.
Next, we'll go to class 3. Here also, it's going to cause again tachycardia, which we have already seen, but now it is way beyond the compensation. The SPP will reduce, the DBP will also reduce, the output is reduced, and here the patient will now go in for confused state. So, mental state is further altered. Okay. Next, coming to class 4, the blood loss is okay, 2 liters. We have only 5.2 liters of blood in our body. If more than 2 liters of blood is lost, you will have severe type of shock where all of this will be not recordable. So this is quite often you see in your casualty posting or your trauma setup, your emergency posting, that a patient comes with polytrauma, severe trauma, and you're not able to pulse, no BP recording. When you put your pulse ox, you're not able to even get the oxygen saturation. Okay, and here the patient will be in comatose state, not arousable. Okay, this is the extreme version of shock. Now, what are we going to do? How are we going to manage this? So, see, the point is there's hypovolemia. What should you do? You need to give fluids, right? So, class 1, you're going to give just oral fluids. So, just you've given blood and come, what will you do? You'll go home, drink some fluids, juices, liquids, whatever you want, you'll take, right? So, that is just the oral liquids. This can be even in case of your mild diarrhea. Okay, coming to class 2. Class 2, here you're going to start IV fluids. You're going to put a cannula and start. Yes, you will give crystalloids. Very important, crystalloids. So moving on, when there is a lot of blood loss with crystalloids, you're going to also start
Blood.
some colloids. Colloid, yes, blood definitely, or you can also start colloids. So alternative with blood. Then coming to class 4, there's no other alternative option here but to give blood. Most important resuscitative measure that you will take in type. Yes, you should give blood. Okay. So we have finished the different types of hypovolemic shock. Now let us go on to check the other types of shocks. That is, next we're going to check out the cardiogenic shock. So this shock is in surgery. So I'll brief it up very quickly. So here, because the heart is not able to pump. So the heart is not able to pump. That's why there is perfusion, right? So it could be because of a number of reasons. It could be because of the systolic dysfunction of the heart. Okay, like heart, it is undergone what you call as myocardial infarction, right? Or diastolic dysfunction. That means the heart is not able to fill.
Yes, ma'am.
Yes, it's not. Yes, it's not going to fill much. So if it's not going to fill, it's not going to empty. So there is decreased heart. That is cardiac output. So it could be because of ventricular hypertrophy. Yes. Then it could be because of restrictive cardiomyopathy. correct? And
Cardiac tamponade.
could also be because of cardiac tamponade. Yes. So that means there's trauma and there is a massive amount of blood in the pericardial space and the heart is not able to fill during the diastolic phase. This is the cause of systolic failure. These are the causes of diastolic failure. Okay. And it could also be because of the valvular defects also, like papillary muscle rupture,
Okay, ma'am.
which could also be because of your MI. Okay. And then AR and MR, aortic regurgitation and mitral regurgitation. Right? So these are all the causes. Now, what is the exact mechanism of cardiogenic shock? It's pretty simple. See, we have the heart. Heart is having this impaired ability of impaired ability of the left ventricle, correct? Because of which your cardiac output is less and hence your tissue perfusion is less,
Yes, ma'am.
right? So this is nothing but your shock. Here you have shock. Now another component which is important is that there is backflow, right? So because of the left ventricular filling pressures are more, because you're not throwing out anything, everything is going to get stacked up in the left ventricle. So the left ventricular pressure is going to increase, correct?
Yes.
And hence it is going to increase the left atrial pressure as well. That's back pressure, right?
Yes, ma'am.
Do you follow me?
Yes, ma'am.
So the left ventricular pressure, it's going to communicate. There's left atrial pressure which is increased, which is again further communicate with the pulmonary arteries and the capillaries. So
Yes.
there's increased, yes, pulmonary artery and capillary pressure. Okay, so this is going to result in what is called a pulmonary edema.
Okay, ma'am.
So this is a type of shock where you're going to have pulmonary edema. That is very, very definitive of cardiogenic shock. Okay, so now if let's say talking about the clinical shock that we saw, if there's impaired ability of the heart to pump, what happens to the BP? Heart is not pumping, so the BP is going to reduce.
Yes, ma'am.
Correct?
Hypertension.
Then what happens to the JVP? Yes. So what happens to JVP?
Increased.
Jugular venous pressure.
Increased.
It is going to increase. Yes, because the heart is not able to pump. There's stacking of blood in the right ventricle, right atrium, and hence back pressure into the jugular system. So you're going to see increased JVP. Okay, and if it's on the left-sided failure, you're going to see basal Krebs, which we just explained.
Pulmonary
Right? It is nothing but you because of your pulmonary. Correct. Now, if it is because of cardiac tamponade, what is a triad? There's something called as a Beck's triad.
Yes, ma'am.
Beck's triad. So what is happening in Beck's triad? One is
Muffled
you're going
heart
to have yes, BP is going to reduce with muffled heart sounds. Okay, and you're going to have increased JVP. Correct. So this is your triad, Beck's triad, which is you're going to see this in cardiac
tamponade.
Right. So this is how you pick up the cardiogenic shock. Okay. Okay. Right. So let's continue. We'll move on to what is called as the septic shock. So that finishes cardiogenic shock, and let's move on to septic shock. Now, septic shock is because of an infective cause, right? It could be bacteria, fungi, or even virus. So it's more commonly seen with the bacteria, and that too it happens to be gram-negative. Gram-negative bacteria. What is the specialty of gram-negative bacteria? Is that their wall, they have something called as your endotoxins.
Release of endotoxins.
There's something called endotoxins. Contents of the cell wall of gram-negative bacteria. Endotoxins are the ones which are going to initiate the whole process of shock here. Now, what these endotoxins will do is that it's going to cause vasodilatation. dilation. So this is nothing but inflammatory mediator now. So it's going
Yes,
to cause vasodilation. Okay, vasodilation, and it's going to increase the capillary permeability. So these are the inherent properties of an inflammatory mediator, correct? So you've studied the rubor, calor, dolor. It is all because of the inflammatory mediation.
yes, ma'am.
It's going to be causing dilatation and increased capillary perfusion. Now, because of the vasodilation, something very important happens. That it's going to cause warm peripheries. Correct?
Yes,
This is contrasting from what we studied in hypovolemic shock,
hypovolemic.
wherein you're
Cold
going to have
periphery.
cold peripheries because of increased vascular. Exactly. Now you're going to have warm peripheries. Right?
Yes,
Next. Here also, this endotoxin is going to cause damage to the vascular, endothelium. Okay, it's going to cause endothelial damage. Right? And further, it's going to increase the vasodilation and the capillary permeability. So endothelial damage will cause settling of platelets and all the other cells to stick onto the wall, right? Because the endothelium is damaged now. The blood will no more flow in a laminar fashion. So it's going to cause thrombosis. Ultimately, thrombosis in multiple organs will result in organ failure, resulting in what is called as MODS, multi-organ dysfunction syndrome. Okay, which will ultimately lead to death. Correct?
yes,
So that is how the septic shock, whole of the septic shock functions. Okay. So one thing to be remembered here is the warm peripheries. Don't forget. Now, what will be the clinical features of septic shock? Sepsis. So infection. You will have fever.
yes,
Okay. You'll have chills.
right.
Chills and rigor. Right. And then you will have warm peripheries here. Okay, and then you will have decreased BP as usual, which is a feature of shock, and some infective foci will be there. Will be some infective foci. If you see, there could be diabetic foot, it could be necrotizing fasciitis, or some foci of infection will always be there. Okay. Now, when you talk about septic shock, now septic shock has two phases. We have the warm phase and the cold phase. Warm phase and the cold phase. Warm is what we studied, where your peripheries are warm. Correct?
Yes,
Because of vasodilatation.
dilation.
Next, cold phase, once the infection is overwhelming, okay, when it is taken over your whole of your system, the endotoxin will act on the heart. Okay, so we have the heart being affected. So the endotoxin has gone up heart. So now heart will no more function. Now this cold phase is similar to what you called as the cardiogenic phase or cardiogenic shock. Right? So the phase 2 of septic shock, the cold phase of septic shock is similar to cardiogenic shock. That is, the toxins have caused myocardial reaction. Okay, hence the myocardial function is reduced and it's not able to pump, and it's going to result in decreased tissue perfusion. Is that clear?
Yes, ma'am. It's
Okay.
after infection subside, ma'am.
Sorry?
It's after infection
It
subside.
is?
Cold
Yeah,
phase.
no, the infection is going to, yes. So the warm phase is when you have some amount of infection. When it overwhelms, when there is an increased infection,
Okay,
right?
ma'am.
It's in the cold phase. It is basically the progression of the disease. So it goes from warm phase to cold phase and ultimately leads to death of the person. Okay?
Okay.
Right. So now let's move on to one more very important type of shock, that is a neurogenic shock. So this is neurogenic shock. What happens in neurogenic shock is that there is loss of the sympathetic tone. Very, very important. Loss of sympathetic tone. It could be because of, let's say, trauma to the spine. Okay, so there is transection of spine and there is loss of sympathetic tone. Very important. Once there is loss of sympathetic tone, okay, what happens is it's going to cause, there is no noradrenaline, no adrenaline. This is exact opposite of the compensatory mechanism we studied in hypovolemic shock.
Yes, ma'am.
Correct?
Mm.
This is exact
Yes, ma'am.
opposite. Now there it caused tachycardia. Now here it's going to cause
Bradycardia.
Right. Yeah.
tachycardia. Correct? And then there it caused increased total vascular resistance. Now here
Yes.
it is going to cause vasodilatation. Is it clear?
Yes, ma'am.
There, because of respiratory mechanism, sympathetic activation resulted in increased heart rate and increased peripheral vascular resistance. Here, because of blockade of the sympathetic tone, it's going to result in bradycardia and vasodilatation, which is exactly opposite of what we studied in the compensatory mechanism. Make sense?
Yes, ma'am.
Now, in most of the shock, what we have seen is there's going to be tachycardia. You see hypovolemic, there's going to be tachycardia. Here, in septic, there's going to be tachycardia. In neurogenic, there is bradycardia. This is the only type of shock where you're going to see bradycardia. Fine. And vasodilatation will lead to what? Cold or warm peripheries?
Warm peripheries.
Warm peripheries.
Warm peripheries.
So this is one more condition where you see warm peripheries. Yes. So we saw warm peripheries in the warm phase or the warm septic shock, early phase of septic shock, and also in neurogenic shock. Correct?
Yes, ma'am.
Now, what could be the causes? As we said, it could be because of the cervical spine injury or a massive head injury or a deep GA or even cephalic migration of the spinal anesthesia. So once you've given spinal anesthesia, the person is sleeping. So let's say this is the normal curvature of the spine. Okay, here you have given the spinal anesthesia. There is cephaloid migration of the spinal anesthesia, or it could be because of deep GA. So these are all the causes of neurogenic shock. Now, let's look at what is called as the anaphylactic shock in brief. Anaphylactic and hypoadrenal shock. Anaphylactic is basically because of your, let's say, an insect bite or exactly. So that is nothing but your type 1 hypersensitivity reactions, right? So here the drug, yes, drug of choice is going to be always adrenaline.
Adrenaline.
So drug of choice, yes, anaphylactic. Anaphylactic, the drug of choice is always adrenaline. I'm going to give a table which is going to summarize the different types of shock. So this table, you're going to help me finish it. Okay, you're going to tell me the components, and I'm going to write it down. Okay.
Okay.
So first, we'll talk about the hypovolemic shock. Let's write it neatly. This should be in your notebook. This is very, very important. Hypovolemic shock. Then let's contrast it with cardiogenic shock. Then contrast it with neurogenic. Then we're coming with septic shock. That too, we have the warm phase and the cool phase. Okay. So now, what are the parameters that we're looking at? We're looking at pulse rate. We're looking at SBP, nothing but just your BP, and then the cardiac output, the JVP, okay, and the peripheral vascular resistance. Okay, so now you're going to help me fill this. Let's use red for hypovolemia. What happens to the pulse rate in hypovolemic shock? Pulse rate is going to
Pulse
Increase.
what
rate
happens to
increase.
increase? Correct? Tachycardia. What happens to BP? Let's say this is an uncompensated. It's uncompensated.
Uncompensated, that is decrease.
Decrease.
Hypotension.
Decrease. Very good. What happens to cardiac output?
Decrease.
Reduce.
Very good. JVP?
In-
JVP will also be decreased. The whole volume is decreased, right? The whole volume. It's hypovolemia. The whole of intravascular volume is less. Correct? So hence your JVP will also reduce. There's nothing, the blood is less. So there's nothing causing the jugular venous pressure. Correct?
Yes, ma'am.
Now, peripheral resistance
Increase, ma'am.
is going to very good because of sympathetic compensative mechanism. There's going to be increased peripheral resistance. Okay. Now let's take another color. Let's fill in for cardiogenic. What happens to pulse rate in cardiogenic shock? It may increase or decrease. This is the point here. If it is, let's say, MI, what happens to heart rate? It is going to reduce. Let's say if it is because of, yes, if it's because of arrhythmias, let's say ventricular arrhythmias or atrial tachycardia, it's going to increase. Pulse rate could be more or could be less. Now, what happens to BP?
BP
Heart
is
is not
decreased, ma'am.
yes, good. Cardiac output?
Also decreased.
Reduce.
Yes. JBP?
Increased.
Very good. And then peripheral resistance. What happened to the peripheral resistance? Again, it is going to increase. Increase. Peripheral resistance is going to increase. So it will again try to cause constriction of the vessels so that you'll pump in more blood into the heart by increasing the venous return. Okay. So now you need to tell me here what happens to the peripheries. Here, what happens to the peripheries? Is it cold or warm?
Cold.
Cold.
Here. Here also peripheral vascular resistance is more.
This is also cold.
Cold. Very good.
Only neurogenic form.
Yes. Now let's fill in for neurogenic. What is happening to pulse rate in neurogenic?
Neurogenic
No
also.
sympathetic. There is no sympathetic activity, so there is no noradrenaline. No noradrenaline. The heart is not stimulated, so it's going to cause
Decrease.
bradycardia.
Decrease. Bradycardia.
Yes. So, bradycardia. Correct. So now what happens to the BP?
BP also, ma'am.
BP
Reduce.
reduce. Because it's shock. Yes. Cardiac output
Reduce.
Reduced.
yes. And JVP? JVP is also reduced.
Reduced.
Volume is also reduced. No? Peripheral pooling. So centrally the volume is less. Correct. Now what happens to the resistance? What happens to the peripheral vascular resistance?
Decrease because sympathetic action disruption.
Yes. So there's no activity. It's going to cause what do you call vasodilation. Once there's vasodilation, peripheral resistance is going to be less. Now it's going to cause cold peripheries or warm peripheries?
Warm periphery.
Warm peripheries.
Yes. Because it is vasodilation, it's going to cause warm peripheries. Okay. So now let us look at this. Warm phase of septic shock. That is the early phase of septic shock. What happens here? Pulse rate is?
Pulse rate.
What happens?
It's a tachycardia, ma'am.
Is increased. It's nothing attacking. No. Yes. So what happens to the BP? BP is high or low? It's shock.
Decreased.
Okay. Cardiac output?
Decreased.
So what exactly happens in, let's say, the early phase of septic shock is that there's going to be tachycardia and it's going to cause increase in your BP. See, there is going to be increased peripheral resistance.
Yeah.
Here also it's going to cause increase in, yes, it's going to cause increase in your peripheral resistance. Okay, so let's see here. BP, okay, output is also kind of reducing. JVP, it may increase or decrease. There's nothing much here. But here it's going to cause warm peripheries. We have learned that the toxin is going to cause vasodilation, correct? And increased capillary perfusion. Is that right?
Yes, ma'am.
The endotoxin is going to cause vasodilation and increased capillary perfusion. Now, because of vasodilatation, it's going to cause warm peripheries. So your peripheral vascular resistance is going to decrease. Correct? That's why the peripheries are warm. That's why this is the early phase or the warm phase of septic shock. Correct?
Okay, ma'am.
Is this clear?
Yes, ma'am.
Is this clear?
Yes, ma'am.
Okay. Now let us go to the last phase, the cold phase. This is nothing but your similar to cardiogenic phase. So again, here the toxins are going to act on the heart. The heart is not able to pump. So what happens to pulse rate?
Increased.
Pulse rate. Heart is not pumping. So what happens to the heart rate?
Ma'am,
It's going to reduce, no?
yes, okay. Yes, ma'am.
Okay. Do you need me to repeat this point again?
Yes, ma'am. Systolic blood pressure also decreased.
So heart पे काम कर रहा है. So heart is now affected. So pulse rate is going to reduce. The BP is going to reduce. Correct. Cardiac output is going to
Yes.
reduce. The JVP is going to
Increase.
increase. Okay. Yes. And the peripheral vascular resistance now is also going to increase. Now it's caused vasodilation. Everything, all that phase is over now. Correct.
Yes.
Now, if you can see one thing, this and this are the same.
Yes, ma'am.
That's why I said the core septic shock is nothing but your cardiogenic shock. So this table is extremely important, right? So this is going to summarize the whole. Is there any doubt here? Should I go over some points again?
Yeah, no, ma'am. Yes.
No, ma'am.
Okay. You just write this table for yourself. Practice this 2 or 3 times at home. Okay, after the class, write this down and go on filling. Logically think what happens to the pulse rate, what happens to BP, what happens to peripheral vascular resistance. So these are the only three most important. If you want to eliminate the others, or just check these 3 to 4 parameters. The others are fine. Even if you leave out the cardiac output, also it's okay. So these three things are important for understanding the concept and also for answering the questions, the MCQs.
Okay, ma'am.
Okay? Fine. Okay. Now let's finish the class with a word about what is called as hypoadrenal shock. We have mentioned something called hypoadrenal shock, right?
Yes, ma'am.
So what is this? It's in the name. Hypo meaning decreased,
Decrease.
adrenal meaning activity of
Adrenaline.
the adrenal hormones. Yes, correct. So what could be the reason for this hypoadrenal shock? See, what happens is normally, let's say there's a stressful condition.
Yes.
Okay, the body is going to meet a stressful. You know, this adrenaline hormones are flight of right hormones, right? They're nothing but it helps us to cope. It helps the body to cope against the stressful situation. So
Yes, ma'am.
stress, let's say injury, okay, which is again a stressful condition, or so these are all the conditions where, or a particular a long-standing illness, right? So these are all the stressful conditions that the body faces. So in these conditions, it should be there should be increase in the secretion of cortisol. So this is the stress
Okay.
hormone. It helps us to cope up with the stress. For some reason, in hypoadrenal shock, there is a reduced cortisol. There is no cortisol, right? So again, it is because of this, there is no resulting decreased sympathetic activity and shock. Do you get the mechanism?
Yes, ma'am.
Do you get do you get the mechanism? Cortisol will loss, so it means reduce NORAD activity or reduce adrenaline activity. So this is nothing but sympathetic activity is lost. Again, it's going to result in shock.
Yes,
Okay.
ma'am.
Now I'm just going to enumerate the causes of hypoadrenal shock. It could be because of adrenal insufficiency. There's something wrong with the adrenal gland. This is your adrenal gland. Gland ko kuch ho gaya. There's something wrong in the gland. See, it could be either idiopathic atrophy, right? So the gland has undergone or in India, the most common cause will be
Mhm.
tuberculosis. The tuberculosis does not spare an organ, so it can involve the adrenals also, and it can lead to the adrenal insufficiency. Correct? Or it could be because of, let's say, amyloidosis, chronic inflammatory condition, amyloidosis, metastasis, right? Metastasis, then bilateral adrenal hemorrhage into the adrenals.
It's 5 o'clock.
Okay. And then last is the use of the drug etomidate. Etomidate is an anesthetic agent. Okay, its use in some studies have shown that will cause adrenal insufficiency. So these are the causes of adrenal insufficiency. But what do you think is the most common cause of adrenal insufficiency clinically?
TB. TB.
TB, yes, in infective cause, correct. But more commoner than TB. See, we put patients on steroids for some reason. There's so many
Yes, ma'am.
in conditions where the drug of choice is.
Exogenous
Yes, so
glucocorticoids.
exogenous. Yes, exogenous steroids. So what will happen if you're giving steroids from outside? It's going to suppress the inherent production of steroids. It's going to suppress the pituitary and the adrenal. The axis is going to get suppressed.
Feedback mechanism.
So you're not producing yourself, correct?
Yes, ma'am.
Okay, makes sense. Okay, so that is about the hypoadrenal shock. And lastly, there's a word about the indices. How are you going to see what is the severity of the shock and what will be the prognosis of the patient, right? So there's something called a shock index. Okay, so shock index is nothing but your heart rate upon your systolic BP. Right, so the important factors to check whether the patient is in shock is going to be heart rate and BP, correct? So shock index is nothing but heart rate upon BP. And there's something now called as the modified shock index, MSI. So what is the modification here? You keep the numerator as it is. The denominator is nothing but your mean arterial pressure. Yes, so instead of taking just SBP, now you're taking the mean arterial BP. Any idea what is the formula to calculate MAP? This also you must have studied in physiology. Arterial PP is equal to
Pulse pressure
DBP
plus
plus
one third of the pulse
yes.
pressure.
Yes, exactly. DBP plus one third of pulse pressure. That is how you calculate the mean arterial pressure. Okay, so these are the two important indices to use. Which do you think is better, shock index or the modified shock index?
Modified is better.
Obviously, so the modified is much better. Now, what does it say? If let's say our MSI is more, if MSI is more, what does it mean? That the heart rate is more, your BP is less. So the patient is doing better or bad? What does it say?
Ma'am, it's
See,
bad.
heart rate is more.
It's
It's
bad.
bad, exactly. So your BP is less. Yes, your BP is less, and there's tachycardia. That means your body is going for the uncompensated phase. So it is bad for the patient, and it is a hypodynamic circulation. It is a hypodynamic circulation. Now let's say the MSI is less. That means the increase in the heart rate is not much, and your BP is kind of maintained. Your denominator is big, so hence your MSI is not that big of a value. So it suggests it's a hyperdynamic circulation and it is good for the patient. Correct?
Yes, ma'am.
Make sense?
Okay, ma'am.
You get the math, numerator relation?
Yes.
Okay. So now I've just mentioned what is the drug of choice for cardiogenic shock?
Ma'am, non-adrenaline.
Okay, let's. Yes. Okay. See, so for anaphylactic,
adrenaline.
We said it is adrenaline. Correct. So A for
Adrenaline.
A. Don't mind my. Yes. So anaphylactic and adrenaline. If it is cardiogenic, the heart is not pumping. What do you need to give? You need to give noradrenaline.
Yes, ma'am.
Right? Noradrenaline heart, so you should give noradrenaline. And there's also another drug which is called dopamine. Okay, dopamine is also going to stimulate the heart. Correct.
Yes.
Now, what is the use of dopamine in cardiogenic shock? There is a logic here. So, what is it that you need to know is that when there is heart failure, okay, so the heart is failing here, and along with that, the perfusion to the kidney is going to reduce.
Yes, ma'am.
So, it is going to reduce the perfusion. And if the kidney is going for what you call as a pre-renal acute kidney injury, so if the renals are going to go for a shutdown or going for renal failure, then your drug of choice will be
Dopamine.
Because dopamine is going to stimulate the heart as well as increase your kidney perfusion.
Yes,
correct? Now, if kidneys are fine, only your heart is not fine. So which will be the drug of choice?
Noradrenaline.
Non-adrenal.
Noradrenaline. Okay, remember this. Dopamine is for the kidney and noradrenaline is for the heart specifically. Okay. Now, there's if it's hypoadrenal shock, it's very logical. If there's hypoadrenal shock, what will you give?
Hypo. What, ma'am? Hypoadrenal steroids.
Yes, so you give glucocorticoids because that's what is lacking. And you give glucocorticoids, and the patient will be fine. So for hypovolemic shock, what will you do?
Hypovolemic, that is fluid. IV fluid.
IV fluids,
Yes,
colloid
we're going to give
crystalloid,
fluid.
Crystalloid.
Crystal, then colloids, then you're going to go for okay. And if it is septic shock,
Broad spectrum
antibiotics,
antibiotic.
you're going to very good. You should give broad spectrum antibiotics, correct? Broad spectrum antibiotics, and along with that, you should take care of even fluid resuscitation.
Yes, also.
Correct, because in septic shock, what happens many times we've seen clinically that their creat and urea levels will increase. Okay, because what happens is they're going for shock now. There's a decreased perfusion to the kidneys. So what happens to the creat and urea levels? It's going to build up. So it can lead to AKI. So
Yes.
in septic shock, you need to make sure that you maintain fluids for the circulation and also address the infection. So hence you give broad spectrum antibiotics. Okay, is it clear? Can we move on to some questions now?
Okay, ma'am.
Are you ready to solve some questions? Okay. One second. Can you see it now?
Okay, ma'am.
Okay, hold on. Okay, can you see it now?
Yes, ma'am.
Are you able to see the questions? Can you see the PPT?
Yes, ma'am.
yes,
Okay, cool. So be quick when the question comes, just try to give me your answers. Okay, shock is best assessed by urine output, CVP, BP, or hydration.
Urine output.
What do you think is the answer?
urine output,
Urine output. Exactly. So that is the one of the clinically what do you call the best indicator of shock. Okay, the tissue perfusion is always urine output. Okay, very good. Now, immediate management of patient with multiple fracture and fluid loss includes the infusion of
Ringer's
Ringer's
blood,
lactate.
Ringer's lactate. Why? See, the question is nothing but okay, they're asking you hypovolemic shock, right? Multiple fractures, fluid loss is going to result in hypovolemia.
Hypovolemic.
So the management of hypovolemia with fluids.
Crystalloid.
Which is the best fluid? Which is yes, which crystalloid, normal saline or RL?
Ringer's lactate.
RL, because RL, yes, it is more physiologic.
More content
It's as
electrolyte.
good as your exactly. So the answer is Ringer lactate. Correct. Next, in trauma case, shock is most likely due to which of these? Injury to intra-abdominal solid organ, head injury, septicemia, or cardiac failure.
Injury to intra-abdominal solid organ.
abdominal solid organ, A.
Yes, right? It causes what? What does it cause? Again, it's going to cause bleeding. Heavy
Hypovolemic.
bleeding. Yes, it will cause hypovolemia. Okay. Neurogenic shock characterized by
Hypotension and bradycardia.
very good. Right. So first thing that should come to your mind is no sympathetic tone. So hence no sympathetic tone on that. It's going to cause bradycardia and hypertension. Correct. Good. Now, one of the earliest indicator of, about the spelling, is concealed acute bleeding. If there is concealed, that is a hidden acute bleeding, what will be the earliest indicator of that? So, concealed bleeding is what? Which is going to result in again?
Hypovolemic shock.
Hypovolemia. Very good. Hypovolemic shock ka feature is?
Tachycardia.
Cold clammy
Very
finger.
good. So,
Also, ma'am,
Tachycardia.
cold clammy finger. Yes, tachycardia is the earliest. Oliguria will also occur. Cold clammy fingers will also occur. But the first one to occur is going to be tachycardia. Correct? Very simple. As soon as there is activation of sympathetic system, you see tachycardia. So tachycardia is one of the earliest indicator of hypovolemic shock. Okay. Now, the most important cause of death in septic shock is. Now, if you listen to the class properly, the different phases, the warm phase, the cold phase, you will answer this correctly.
Cold phase, that is cardiac failure.
Yes, very good, very good. So it's the cardiac, because the late phase septic shock is called septic shock, and cold septic shock occurs when the endotoxin is going to affect the.
Ma'am, if we go to actual cause,
Sorry?
it's if we go to actual
So
cause, it's the MODS.
Correct. Actual cause it is MODS. Truly agree. But the most important cause of death in septic shock would be the disease progresses from the warm phase to cold phase and then death. Correct. And again, if you see MODS, multi-organ failure system, correct?
Yes, ma'am.
Or multi-organ dysfunction syndrome. Is cardiac system also included in MODS?
Yes, ma'am.
Is cardiac system also included in MODS? Yes. So according to you, MODS is the right answer. And there's so many organs involved in that. And cardiac happens to be the first thing to fail. So it will be the most important cause of death. Do you get it?
Yes, ma'am.
Okay, let's move on. Okay. Now, blood clot, the size of a clenched fist is roughly equal to
100 ml, ma'am.
250 mm,
This
ma'am.
is very. It is actually 500 ml. Okay, its usage is seen more in OBG, where you have, once your placenta delivers, you have a lot of clots coming out. If the clot size, okay, if it's more than or equal to clenched fist, okay, the size of clenched fist, it means that the patient has lost around 500 ml of blood. Okay, that is, it will be class 1 hypovolemic shock. Do you remember that volume?
Yes, ma'am. 500.
500, 1,000, 1.5 liters, and more than 2 liters. Revise that table clearly again. Okay. Now, green colored IV cannula. What is the size of green colored cannula? If you have visited your hospital rounds during the internship, you would have noticed.
Yes, ma'am.
Have you seen cannulas? What are the different colors you've seen?
Green, pink.
Yes.
Actually.
Have you seen blue colored? Blue.
Pink also, grey also,
yellow.
red also.
Very good. See, so for green color, it is 18 gauge needle. Yeah. 18 gauge. Now there is one picture here that I want you to have a look at, that they might ask you. There are different colors of the color coding of the cannula and the size of that. Okay, orange we don't normally use it, but it is 14 gauge. Like if you see the most commonly used, that is green and pink. Green is 18, pink is 20.
Yes, ma'am. Pink.
Okay, now as the gauge increases, as the number increases, have a look. 14, 16, 18, 20. Now look at the flow rate on the right side. So how many ml per minute? If the orange one is 240, gray is 180, green is 90. So if the number increases, the gauge number increases, the diameter is going to decrease, and hence the flow rate is going to decrease.
Yes, ma'am.
Correct? So just remember, bigger the number, lesser the flow. Okay? Bigger the number,
Okay, ma'am.
Lesser the flow.
just try to remember this in your. Yes. If you keep seeing these cannulas, remembering it, green is 18, pink is 20, blue is 22, yellow is 24. Violet, we hardly use it. For pediatric patients, we use it. Okay, that is 26. And for blood transfusion, which one do we normally prefer? Do we need a bigger bore cannula or a smaller one for blood
Smaller, ma'am.
transfusion? Smaller or bigger? See, for blood transfusion, we need the RBC, the cells to, we'll have to squeeze through it, right? So we need a bigger size cannula. Normally we use green, anything green and above for that. Okay,
Okay, ma'am.
let's move on. We made a note of. Okay. And here is the picture. Have you seen procedure anytime in your hospital? See, this is called intraosseous cannulation. If there's a child, let's say less than 6 years, has come with shock, and you're not able to get a peripheral line, you're not able to put a cannula. Okay, you've tried 3 times, all the 3 times you've failed, and it is more than 90 seconds that you're trying to cannulate the patient. The next thing you would do would be to put an intraosseous cannula, that is into the bone. Okay, you're using a
Okay,
cannula
ma'am.
and you're going into the marrow, tibial marrow. So you will go around 2 to 3 centimeters below the tibial tuberosity, as you can see in the picture, and you're going to go. Do you get that? And then you will go into the marrow and you give the fluids through that. This is nothing but intraosseous cannulation, which is normally done in children less than 6 years.
Okay, ma'am.
Is that okay? Okay. So that marks the end of this session. I hope you guys enjoyed it, and I hope you learned something. I hope it was useful. And if you have any doubts or any questions, you could raise them now.
Ma'am, actually, there are so many questions about blood loss and about classification of the shock. Uh, there are questions if is it given 15 or 30 means particular, then it will come under class 1 also and class 2 also. Then which class would
Yeah.
you put in this controversy?
To follow. You look at the clinical features as well. If you look at the clinical features, look at the pulse rate, you look at the BP. So we drew that table, right? The class
Means
1 to
ma'am,
class 4
there is
of
no in give no extra features are given. If there is extra features are given,
okay.
we can trace whether it is class 1 or class 2. Only due to blood loss amount, if there is a 15%, then what will be the class? The
50.
class 1 or class 2?
Yeah, see, you take it as class 1. When a patient comes into your emergency room or something, there's no clear-cut numbers as such.
Actually, yes, ma'am.
You're going to see the patient completely. You're going to look at the clinical. You do the clinical examination. You're going to look at the pulse, the heart rate, and all other features. 1 and 2, you're going to take decisions. So now, see, if it is 15%, it is less. So you can actually give him oral fluids. You can put IV cannula. So the management also, there's going to be an overlap. So you mark the answer which seems more appropriate.
Ma'am, actually, I solved the means previous year question before some days, 15 to 20 days back. I found some 15% maybe there. They're given at class 2, ma'am. That's why I confused because class 1 also 0 to 15% and class 2 also 15 to 30%. That's why I am confused.
Okay. I think it should be seen more of a complete picture, as I said, along with the other features. If not, you take it as class 1.
Okay, ma'am.
Okay. Anything else?
No, ma'am.
Okay. Okay. Thank you.